another Supreme Court challenge. The topic couldn't be more timely. So it is my pleasure to introduce our program moderator, MSDC past President, Dr. Eliot Sorel, and our guest speaker, Dr. Thomas Zeltner, the former Secretary of Health of Switzerland and Director General of the Swiss National Health Authority. And so Dr. Sorel, the floor is yours. Thank you very much.
Thank you very much, Robert, and Pia, thank you as well. And thank you to you all who've decided to take an hour from your busy day and be with us today. We are very honored and privileged to do a very special program today that is extremely relevant to the United States. And to have as our keynote speaker and guest, a former Secretary of Health of Switzerland and Director of the National Health Authority for 18 years. Professor Dr. Thomas Zeltner, and to do it at our venerable society as its host, the Medical Society of the District of Columbia, that was founded in 1817 by an act of the United States Congress. We also want to extend a welcome to all our colleagues from throughout the United States who are participating and from throughout the world, and a special appreciation for the participation of Dr. Paun, the health advisor to the President of Romania, Klaus Johannes. So we are very pleased and look forward to a very robust dialogue, a timely presentation. Now, why, you may ask, what does Switzerland have to do with the United States? Well, in thinking about which model to look at this particular junction, when America is the only high-income economy that does not provide healthcare to all its citizens, we came up with choosing Switzerland for several reasons. First of all, we admire the Swiss for their precision, for their excellence, and for their innovation. So if you can think about, to remember this, the acronym is SPI. Precision, innovation, and excellence is the hallmark of Switzerland. Additionally, Switzerland is a small country, but it does big things because it thinks big and it innovates. Thinking big and innovating and can-do spirit is very American also. Thinking big, can do. And Switzerland also has significant other challenges, namely, it is not a country that is rich in oil, for instance, or all the wealth that America has, but they are very rich in talent and they invest hugely in education to prepare that talent for those pathways of innovation that they have created. Additionally, Switzerland modeled their constitution after that of the United States. That may be a fact that is quite relevant, particularly since we're talking about policy. Furthermore, Switzerland is similar in some ways, on a smaller scale, to how we are organized administratively. They are a federal republic, as we are a federal republic. And they have the analogous states that they call cantons. So there is federal authority, but a significant degree of cantonal autonomy, just in a way like our states in the United States. So Switzerland and the United States have more things in common than not, with one major difference. Their citizens, all of them, have access to care that is not tied to employment. We do not have that. We have a great deal to learn from them, and we hope Professor Thomas Zeltner will demonstrate that to you, and we'll develop that in our dialogue with each other. It is a huge pleasure and distinct privilege to welcome back virtually to the United States my friend Thomas Zeltner, whom I've known in the years preceding the Obamacare activities that we are both engaged in. Thomas, the floor is yours. Thank you very much for being with us.
Well, thank you so much, Eliot, and all dear participants to this seminar or meeting. I'm very happy and very glad to be here with you today. And to all what Eliot said, there is one thing I really want to add. What is relevant between Switzerland and the United States is that so many medical doctors and leaders in health actually have a deep affection and a deep gratitude to the United States, because I would say more than half of us have actually spent a couple of years in your country and have learned a lot in your country, from your country. Me, for instance, I spent a few years at the Harvard School of Public Health, and I would never ever have been able to do what I did in Switzerland without all the education I was privileged to get in your country. And that's really very true for many of us. I share Eliot's already given answer. Is the Swiss model relevant for the United States? My answer is clear, yes, it is. And what I would want to do in the next 20 minutes or so, maybe a little longer, is really to give you a view, why is it? Next slide, please. The Swiss healthcare model actually is what we call a regulated healthcare model. And next slide, where there are only actually 3 countries in the OECD countries which have a system of regulated healthcare, namely the Netherlands, Switzerland, and to some extent the United States. And you know, the father of this model is actually Alan Enthoven from Stanford. And Alan actually wrote a couple of papers in the 80s last century. And when the Swiss government had to decide on in which way should we actually evolve our system in the early 90s, there was, after a long debate in the parliament, the consensus that we should run and go for a regulated healthcare model and follow more or less Enthoven's prescription. And how do this model look in Switzerland? Next slide. And go through. And for Switzerland, as in many other countries, really the 4 key actors in the system. Let me start with the most important: citizens, customer, patients, healthcare providers, the government and the regulator, and in the case of Switzerland, and we will see that, health insurance companies. So how do these actors interact with each other? Citizens are actually free to choose a health insurance company. There are about 50 of them in Switzerland. Next slide, or next, yeah, just. And they can actually choose from them annually and can change the health insurance company if they want every year, every end of the year, when they get a new premium bill, and compare that premium bill with others. So the choice is really one on civil rights. It's like a contract between the patient, the customer, and the health insurance company. The only compulsory element in it is that you need to choose a health insurance company. We decided on that in '94. Like the United States, before this and before your Obamacare, we had something like 95% of the population who already had an insurance company or insurance, health insurance. And then we moved on to make it 100%. And I will come back to that in a minute, how that was implemented. The same thing is true for the relation between the patient and the health service provider. In Switzerland, you're free in the basic package to go to a family doctor. You're free to go to any specialist you want, even before going to a family doctor. And so the choice is very big. You can also, of course, go to the emergency service, and normally you need a healthcare provider, a doctor, to get you into the hospital. So there too, there is, I mean, a huge freedom of choice. And the only point where we really don't follow Enthoven's model totally is there is a compulsory contract between all health service providers and health insurance companies. So health insurance companies are actually not allowed to not have a contract with a given service provider, even if the one is really way too expensive, and it's a very complicated process to get out. Before 94, employers were in the game too. Some of the health insurance plans were related to the job. We decided then to get rid of that, and next slide, or next step, we actually got the employers out because we thought that it is better for patients, it's better for the employment, that there is not a link between your employer and the health insurance, because nothing worse than just staying at your company because you don't want to lose your health insurance plan. So we did that. We had to increase the salaries of the people in order that what the employers paid in the past will now be paid by the patients, so that the insurance company could be paid. Next slide. What do we achieve with that kind of a model in Switzerland, or what have we achieved? Next slide. And I just show you one slide here. I could show you quite a number. Our actually health outcomes are among really the best in the world. And let's just take the life expectancy. We're behind Japan. We're number 2. The same is really true for child birth and other factors. Of course, we have to admit that quite a bit of the good achievements is also due to the wealth of the country. As we know, social determinants are very important. Next slide. This is just to show our COVID situation right now. We're pretty much similar to many other countries. We had a major wave in April. For the time being, things go up slightly in Switzerland. We are in a phase where we hope that we can control the infection here. It's not sure, and as other countries, we're pretty concerned how the winter will look like. Next slide. I show you 2 things which are nice. On the other hand, also some disadvantage. If you look at that, you see how satisfied are you with the overall performance of the Swiss healthcare system. You see that 78% say very positive or rather positive. This is actually amazingly high. And I know that the data in the US would certainly not look like that. Next slide. I show you one, which show you one aspect, and that is that 75% of our population is actually in 15 minutes at the next primary care doctor's office, 90% within half an hour. So what that shows is that we have a huge infrastructure. One could actually say too much, but we actually invested so much. And the advantage of this is that people like the system. The disadvantage is that for the time being, it's rather difficult to introduce new major reforms. Next thing. Interesting, the physician satisfaction is also very high. It is among the highest. This is a slide from Commonwealth Fund you may be aware of. And here again, 84% of doctors tell us that they're very happy with practicing medicine in Switzerland. Next slide. Of course, this system has its price, and we have to say that we're probably the second most expensive system after yours. Next slide, you see, and I think this is a very interesting slide. We don't have a cost explosion, but we really have a very linear increase of the healthcare costs every year. So far, they're in a level where most people really can afford it, not all, and I will show you what we do to keep them in the system if they cannot pay for the healthcare bills. Next slides. And the funding is actually as follows. Social health insurances pay about 42% of the total 81 billion the system costs these days. A substantial amount is actually paid by the private households themselves. There is a long debate on how much should people pay out of the pocket. In Switzerland, most of this number comes from dental care, which is actually not insured in Switzerland. Quite a bit of people have a additional private health insurance. You don't need this. It's really just to have single rooms or special service in the hospitals, and then 6% are other funding. So this is the way the system works. What do we do with people who cannot afford to pay their premiums? We introduced a system that taxpayers or the cantons, the states, actually subsidize families or individuals who cannot pay for their healthcare premiums. And that makes up these days 37% of the population, which is quite a bit, that get some or the total. If you're really poor, the total of your premium will be paid by the state. If you're earning more, then it is part of it. Next slide. You may have seen this one, and you don't need to try to read it, but I always think it is a very interesting slide. It actually shows the healthcare spending as percentage of the GDP over time. And as you can see, there is a broad range of countries, all very close together. And again, what is interesting, it's more or less linear. And in this broad range, you find countries like Switzerland, like the Netherlands, but also countries like the UK with a totally different healthcare system, a national healthcare system. So the system doesn't seem to have too much an influence on how you perform when it comes to health costs and health cost increases. And we only have one outlier, and that's the US. And we can, and you know why the US is this outlier in this statistics. Next slide. As a matter of fact, most European and most OECD countries are with their spending and growth rate just always about 2% above the GDP. The US is constantly 2.5% above the GDP. And that makes that, you know, year after year, you're spending substantially more than other countries. The average is now in Switzerland, we have 11.9% of the GDP, and you're at 17.7. As you can see, and that's actually a graph that comes from our Ministry of Finance, we will only be at your level in the year 2060. So it seems to us from that perspective, we should have enough time to adjust our system, not to get to the point where you are. And I think the question you are exposed to is how you're able to bend the curve. And we certainly can come back to that. Next slide. What are the challenges ahead of us? Next slide. I mean, as you have seen, we're exposed to a high and rising healthcare costs. We think we have quite a substantial number of overconsumption in this country. We have quite a number of inefficiencies between different structures, a lot of double examination, double X-rays, etc. Our system still is overly focused on acute care, and one of the challenges we see for the future is really how do we restructure the system that we really take care of the major burden of disease in Switzerland, which are, of course, the non-communicable diseases with a lot of diabetes, mental health problems, etc. Another problem we're facing is a shortage of medical doctors and of health professionals in general. We actually import about 1/3 of our doctors from Germany, from France, and we need to work on that because earlier or later they will not come to Switzerland anymore, and we will have a problem there. Lack of transparency, lack of data when it comes to quality, and finally limited progress in digital technologies. The patient documentation is too often still based in one hospital, and actually patient documentation which is open to everyone over the country is just not yet here. And finally, of course, we need to work on social inequalities as in most countries. We're pretty confident that we're able to do that, and that brings me to the last slide. We're always surprised, and Eliot mentioned that, Switzerland, for reasons which always surprise us to some extent, is an extremely innovative society. We invested, as Eliot said, enormously in education, given the fact that we have no natural resources. And for years, we have actually always been the first, and the US is very close to us very often. Sweden is very good in innovation. And given this fact, we hope that we are able to bring in the innovations we need. And I would say it's cost, it's really dealing with chronic diseases, and it is introducing digital technologies into the health sector as much as it is needed. So that's the Swiss system. And I think what can you, or what could you learn from us? I think for us, it is unthinkable that people should not have access to health care. If you say, and I dare saying that, America first, then I think it has to do with the citizen in America first. And for us, it's almost clear if a house is burning, you want that the government makes sure that there is a fire brigade coming. If someone is sick in your community, it's our feeling that the community should be organized such that there is an access to healthcare possibilities. And as you can see, it can be done, and it can be done with reasonable costs. Thank you, and of course, very open and glad to answer any question.
Thank you very much, Thomas. I just wanted to underline one very important element, namely that one of the fundamental elements of your system is the sense of solidarity and risk sharing.
Yep.
To have a national system that works, everybody has to be insured, everybody has to participate, because illness does not begin and end in only one household. It can spread, it does spread, especially a pandemic is teaching us that lesson. It cannot be contained in one state, in one country. So the concept of solidarity and risk sharing is fundamental to be able to have access to care for everyone. Everyone has to be insured. Before we go to the questions, I want to also add one more credential that you should know, that and to demonstrate that innovative spirit that Professor Zeltner demonstrates himself. WHO is a premier leading world organization on health, but frequently the tasks that it faces are insufficiently endowed with the human and financial resources that they need to be able to face up. And this pandemic probably will reveal more of that need to review the WHO mission, function, and resources needed. And I must congratulate Professor Zeltner for his most recent innovation. He reached out to the Director General of the World Health Organization, Dr. Tedros, and proposed that the WHO establish a WHO foundation that will be distinct from WHO, but related to WHO, a separate entity that will be able to accept human and financial resources to buttress and enhance the WHO mission. Thomas, I want to congratulate you for this innovation.
Thank you.
I want to wish you well on your mission as CEO, and the discussion is open. Please identify who you are and tell us what's your question.
Hi, I'm Jim Colby. How do you make people get insurance? In the United States, we tried it under Obamacare. People often did not take out the insurance. How can you force them to buy insurance?
It's a it's a stepwise procedure. It is actually controlled. In Switzerland, you can deduct your health insurance premiums from your taxes. So if you submit your tax forms to your local authority or to your local community, they will see immediately whether you have a health insurance because you have deduction on it or you haven't it. If you have no health insurance plan and deduction on it, then the regulator will come back to you and say, listen, you have not mentioned your health insurance plan. Please provide us your health insurance. And if someone has not yet a health insurance plan, then they should do it. If they don't do it, then the local government will actually give them another 2 months to choose between 3 health insurance plans, the cheapest one in the regions to choose from. And because it's a private contract again. If they don't do that, then the community actually enforces and chooses one of these health insurance plans. By doing such, we come to a cover of 99% of all population having a health insurance plan. The only problem we're having are illegal immigrants who have no residency and no address. And we were it was a quite difficult question how to deal with them. And in the meantime, there are a couple of philanthropic organizations taking care and serving as a first entry point so that even illegal immigrants in Switzerland normally get the adequate service.
Thank you, Thomas. Any other question? Please identify yourself and mention your question, please.
Hi, good morning, everyone.
Go ahead.
Shall I go? Okay, I'm Mia Keys. I'm with the Health and Policy Management track of DW. I'm in my third year as a doctoral student, and I'm very excited to witness your talk today. Thank you so much for coming. I'm wondering if you can expand a bit on your page where you listed the challenges that Switzerland is facing. I'm wondering if you can expand a bit on plans or research to buttress the social inequities, and maybe allude to some of the ones that are a bit more immediate. I know you talked about people who are immigrating to the U.S. and not being able to really connect residency and so on and so forth. Are there others, and what are the innovative approaches to addressing them? Thank you.
Yep. I'm not sure whether I got all of, Eliot, can you repeat, because there was a noise in the line.
I think if you could expand a bit, how do you deal with inequalities?
Yeah. Okay. Well, as you know, and we all know, the inequalities, the biggest inequality is actually in social determinants of health. The richer you are, the healthier you are, the more educated you are, the better you're health-wise off. And what we try to do is that we try not to have what you have in the US, a segregation of communities. So we don't have that kind of communities where all the rich live and communities where the poor live. And by doing, that kind of a mixture, we succeed in supporting families. When it comes to the most difficult families in Switzerland, then I think it is lower middle class families, particularly mothers with a couple of kids and no father, for instance, or no father in the household. And there we do have problems with, supporting these mothers. We try to do our best, but of course, it is difficult. The unemployment rate in Switzerland has always been very low compared to many other European countries. We are normally at 3.2% of unemployment rate. And those who are unemployed actually get a subsidy from the government. So we try to integrate them as well as we can. But of course, nothing is perfect, and there are certainly families also in Switzerland suffering.
Thank you, Thomas. Thomas, I have a question I'd like to ask. You have presented us a wealth of data, particularly how the projection of costs and how they continue to rise, and they're likely going to continue to rise in the years to come. I believe that when in our prior discussions you and I have had, in terms of the challenges remaining that I do not think you entered into this last slide, is that essentially health insurance plans, including the Switzerland, focuses primarily on addressing illness. They
Yeah.
not address health. And I think one of the challenges that remains for all healthcare systems is to not only address illness, but also to promote health. And I think that likely, this is a hypothesis, I'm not sure what you would think and how you plan to address it, that a key to diminishing the rise in cost is to truly address not only illness, but health, to promote, to protect health and to prevent illness. All health systems do not have that piece well developed yet.
Definitely. And thank you for addressing. I was really more talking about the healthcare system, and you're very right. I mean, we repeated the measures you have done in the US. If you look at the population and look what makes up their health, and you know the data, it's about 10% is genetic, about only 20% is the healthcare system, and 70% is behavior and the environment in which you live. So the major factors influencing your health as a family, as an individual, but also as a community lies in the environment and lies in your behavior. We're less good or worse than you are when it comes to tobacco consumption. I think we're about the same when it comes to alcohol consumption, but we have quite a bit of unhealthy behavior too. We are much better when it comes to obesitas and overweight. We are better when it comes to exercising, fitness, sports, but there is a huge amount of work to do. So one of the strategies of the Ministry of Health is really trying to be a good advocate for health in other sectors, being schooling, being it environment, being it healthy communities. And there is a lot that could be done and should be done in Switzerland. There is a huge resistance in the parliament for that. We have a strong alcohol lobby. We have a very strong tobacco lobby, and it is a huge fight, but we'll not give up on that.
Thank you, Thomas. Any other questions or comments, please? Identify yourself.
Ron Bailey, Elliot, I have a question from California.
Tell us who you are.
Ron Bailey from California.
Hi,
Please,
Ron.
go ahead.
Hi, Ron Bailey. I'm Assistant Dean of Clinical Education at UCLA Drew School of Medicine in Los Angeles, and I am the Chief Medical Officer of the Kedron Hospital System in the city of LA. We're a 72-bed inpatient, county-funded psychiatry inpatient setting for the indigent. Really enjoyed and appreciated your comments today, sir. Wanted to ask a question, make a comment. Really, the comment revolves around the issue regarding an employer-based health insurance plan. I appreciate your comments that once in Switzerland it was determined that if you're going to move away from that system, it would be helpful because individuals wouldn't want to stay in a job they did not like solely in order to maintain health insurance. That really resonated with me because here in California and in the US, that absolutely seems to be an ongoing problem, which I think has downstream negative effects and really impairs our ability to move toward a better overall system. One does wonder, what were some of the antecedents that really pushed, I think, the community engagement and allowed persons in society to hear that message differently in Switzerland, which really allowed you to get probably the groundswell of support you needed to make that change nationally?
Thank you, Ron.
As a matter of fact, we introduced two things in the same time in 1994, namely the compulsory universal health coverage, so that everybody had to have the health insurance plan, And secondly, to, to get the employers out of the system. And as a matter of fact, maybe it was very smartly intended or not even intended, but doing that, as a matter of fact, the whole debate in Switzerland at that time was on the universal health coverage. And we actually had also a popular vote on that, because in Switzerland you can vote on every and anything. And in the law was actually at the end adopted or accepted. But in these debates, the question of the universal coverage was 80% of the debate. And the question of the employers getting out of the system was a minimal part of it. And so somehow making this package, at least in Switzerland at that time, helped.
So I think to sort of bridge the question around the question you asked and the answer from Professor Zeltner, it seems to me there is a cultural difference between the two countries. In your country, your people do take naturally to the concept of solidarity, and that they see a mutual advantage in having everybody covered. In America, we idolize, individual initiatives, and there is a less of a sense of how can everybody benefit if everybody is insured. I wonder, Thomas, what advice would you give American policymakers to be able to translate that message in a way that it can be acceptable to the American people?
At the end, you're very right. A lot of that has to do with culture. And, why in Switzerland did we actually learn this or have this tradition of solidarity? It really comes from our history. And, some of, or many of you may know that Switzerland has three parts, cultural parts. One is a French-speaking part, the other one is the German-speaking part, and we have an Italian-speaking part. And what we normally say is we are a nation of will. If we would not want to live together, we would fall apart. And it has a long tradition that the richer part, and that's a German-speaking part, actually subsidizes the French-speaking part because they had less industry and less technology. And so there is a long, long tradition of understanding if we want to stay together as a nation, we need to support each other, even a whole set of regions. Now, you cannot transfer that so easily to the United States. But I think what needs to be done is to find, roots in your history saying that the prosperity and the well-being of this country has been created by very different parts of the society. And the different parts of the society, in my perspective, deserve that gratitude. They're all paying taxes. They all do their, or quite a number do civil services, etc. That they should also care for each other within a community. I think probably it might be easier to explain that at the level of a state, might be easier to explain that on the level of a community or a town, where people feel we're together in that. And we don't want to lose, the most vulnerable in that system, because at the end, the vulnerables will end up on the streets, end up in the hospitals, and you just can't accept that. So it is an ethical question, which is, I think, easier probably solved in smaller communities, and Switzerland is pretty small with 8 million as compared to the US with your 300 and something million.
Thank you. Any other comments, questions, please?
Hi, my name is Claudia Dima. So I would like to ask you, how is regulated the access to hospital care in Switzerland? Should people have a referral from primary or ambulatory care? And how COVID-19 influenced the access to hospital care?
Yep. Well, no, if you're having an emergency, you always can go directly to the hospital. If you're not having an emergency, but a selective, for instance, intervention, then you need a transferal. Now, another part of the Swiss system, which is amazing, is there are virtually no waiting times. If you have actually a hip problem, you go to your family doctor Monday, you probably are certainly have a chance to get a CT or an MRI Wednesday. And if you wish, you can get into the next hospital the next week. So there are really, that's the reason why we believe we actually have more or less two luxury structures. So for any kind of emergency, you directly go to the hospital. If there is some elective procedure, you need a transferal. Now, when it comes to COVID, we were very concerned about whether the hospital system will be overflooded. So very early in February, March, we actually made sure that enough hospital beds are free. We added quite a substantial number of emergency care beds. And by doing so, in the tip of the first crisis, we never ever had an overflooding of the system, but pretty close to being filled. Whether that will be the same this winter, we have to see. We're pretty concerned, as probably many of you are, with the fact that probably the influenza epidemic and the COVID epidemic will fall together, and that too many of our healthcare professionals will fall ill in the wintertime. But so far, we've gone through that very easily.
Thank you very much.
Thank you, Thomas. Any other questions, comments, please? Tell us who you are and ask your question or your comments, please. Thomas, may I ask you another question? You have identified one of the challenges remaining is the healthcare professionals. We know now that we have a global health professional deficits of about 7.5 million. If we don't do anything, that deficit will go by 2030 to about 12 to 14 million. Are there any initiatives that you and your country are contemplating so you don't be one of the raiders of brains from other countries and create your own talent in your own countries? Because we know Western countries pride themselves in so-called helping with development of other countries, but raiding their talents is an undermining of those countries. So what plans do you have to meet the increasing demand and the diminishing supply of health professionals?
Sure. Well, very good question. We had like two problems in Switzerland. Too few education places, so too few places in medical schools. that's problem one. And the problem two is way too few of the medical doctors going into family medicine or primary health care. Most of our medical students wanted to go or did go in the past years into highly, specialties, orthopedic surgery. We have too many surgeons these days, etc. So we did two things. We increased actually the number of slots in the medical faculties or medical universities by 30%. We opened a new school of medical training in one of the universities who didn't have it. And with that, we are now able to cover more of the need, but not the total. We're still importing doctors because in Switzerland they also earn more. So we need to increase the number of medical students still more. The limiting factor is actually the clinical training. It's not a preclinical anatomy and things like that, but it's really bedside medicine where the difficulty is. Contrary to the US, all studies in Switzerland are virtually for free. Meaning that the taxpayer actually pays for the universities. And we know that every medical doctor costs the taxpayer actually 1 million Swiss francs. And it is more a question, how can we actually motivate the cantons who have universities to increase the number of medical students because it's actually very expensive for the community, but we have done that. The second thing is that we remunerated our family doctors better. We try to give them access to academic training that all the medical schools have now, Institute for Family Medicine, etc., so that we don't have this hierarchy of medical specialties, and that family doctors feel estimated by the society. And I think there too, we're on the good track, but we are not where we need to be. At the end, we should actually be autonomous in training, but we're not there yet.
Thank you. Any other questions, comments, please? Jump in, join us.
I have a question, Professor Zeltner.
Tell us who you are, please. Tell us who you are.
I'm Evian Gordon, based in San Francisco. I'm part of a chief medical officer for an online mental health, big data mental health company with links to a number of payers, the American Heart Association and the AARP. My question was, firstly, thank you for your profound comparative effectiveness insights. My question relates to your one point in the slide about I think you said the limited progress in digitalization. To what extent do you see big data, predictive analytics, personalization, telehealth playing a role in this, and including the ability to cross these national boundaries to move to a more evidence-based outcomes model rather than a service-based model?
Yeah, well, I mean, from an academic perspective and from a perspective of public health, we all think there is a huge potential on it. We see actually two resistances in the society. One in Switzerland that I don't know how much that is the case in the US too, is the question of data protection. Citizens are very concerned about what happens with their data. We don't feel too comfortable that these data should be stored actually at Google and in other global actors. And so there is a debate on having, big data stores that are in Switzerland to prevent all kind of, abuse or misuse of these data. The other area where we do see a resistance in using digital information is actually in the private practice of doctors. They are just, used not to use these technologies, and they feel rather uncomfortable with it. And there is no doubt that they often don't like that other doctors look into what they have been doing, because it is, unfortunately, given the fast development of all specialties, everyone knows that they are back in the latest, or they're not aware of the latest developments, and they feel a little embarrassed vis-a-vis the other colleagues if they see that. But we're working on that, and I think it's only a matter of the new generation. The new generation of medical doctors, nurses feel very comfortable with all these new technologies. And they're saying that vis-a-vis of Sorel, the biggest resistance we actually have with psychiatrists, and psychiatrists beyond 55, 60. They just feel very uncomfortable with the fact of having electronic data pooling.
Thank you, Thomas, and thank you, Dr. Gordon. Building on Dr. Gordon's comments and question, Thomas, would you take a leap, so to speak, and bring us up to date whether there are any new innovative initiatives that integrate information technology with artificial intelligence in service of health and illness?
Yeah, we actually, given the fact, and I did mention that a little bit, it is very difficult these days to have a nationwide major reform of the health system, be it in the field of preventive medicine, be it in the field of chronic diseases, because, and that's the fun thing, because the doctors and the patients are so happy with the current system. So there is no, only the public health community and the government feels we are not ready for the future, and we should actually restructure the system. So what we do is, and the government introduced that, a 5-year period of experimentation where we invite groups to submit proposals for experimenting wherever they feel it is interesting and needed. And so we have a couple, and I'm glad to share that with you in another form, a couple of very interesting projects using artificial intelligence, digital health, and new service provision. So we hope that within a couple of years we will have results, and by showing these results, reduce the resistance. As some of you know, and then I stop with that, some of you know, we introduced in Switzerland the prescription of heroin to drug users. I mean, even in countries like, in most countries it's unthinkable. In Switzerland it was unthinkable at the beginning too. So what we did is actually we said, let's at least give it a trial. Let's at least try it and control it, whether it works or not. And the results were, as you know, surprisingly positive. And that is a little bit in the genetic of Switzerland. We discuss, and then at a certain point, we say, we agree that we disagree, so why don't we try it? And then we can see what, what happens.
Great, wonderful, wonderful.
Dr. Zeltner, what do you call that experiment?
The current one, or the heroin prescription?
The 5-year AI.
That's a government-run phase of experimentation. It's called a pilot trials. And what it also allows, and that goes even further, you can ask the government or the national authority to get an exemption from the current rules. So that if the law says you need to do this and this and this, and you think that this law is prohibiting you from doing something innovative, then you can ask the government to give you an exception and not to follow this law.
Thank you. Continue improving your innovative and flexible spirit.
Right.
Thomas, we are privileged to have you with us today, and I know this was not part of the intended agenda, but I'd like us to take advantage of your being with us today. Would you spend a few moments and share with us your vision for the WHO Foundation and how we can help with it?
Yeah, very glad to do that. Yeah, you know, as you know, the World Health Organization is actually, you know, an organization is run and financed by the member states. And the member states have the saying and should have the saying what the WHO is doing. And I'm not going into the debate that the US is withdrawing from or is trying to withdraw from the WHO. WHO is not created and constructed to accept donations from other sources, except from big foundations like Bill and Melinda Gates Foundation or the Rockefeller Foundation and member states. And we saw in the past as other UN organizations, let's take UNICEF, has actually started to collect money from the general public. They sell cards, they sell this and and from high net worth individuals and from companies. And WHO is just not constructed to do that. So we looked into that and said, let's try to address or these three groups of people: the general public, high net worth individuals, and corporate or the business sector, to, if they wish to donate or to support or collaborate with WHO, that they can do that. I give you a couple of examples. The auction house Christie will actually this fall do an auction of paintings or art giving to them by prominent people. I think Brad Pitt gave 2 pieces, and these art will be auctioned, and the result of these auctions go to the WHO Foundation, and from there to WHO. We are right now discussing with a couple of high net worth individuals whether they are willing to get into what we call a founder circle and to give money to the foundation in order to establish the foundation. The goal of the foundation is very ambitious. We really hope that within 3 years, we can collect an additional $1 billion for WHO and their implementing partners, because not all of the money will directly go to WHO, but a part will go to implementing in Africa in projects. And what we can do and what we are doing is actually discussing with high net worth individuals, where are your ambitions? Then they can actually select, they are interested in health in Africa, they're interested in health of mother and child in Africa, and then we try to build with them projects where they feel that is meaningful for them, and at the same time it helps WHO to get to additional funding. So that's the idea, really to find what we call non-traditional donors for WHO.
Thank you very much. Thank you. Pia, you had a question?
Yes, I did. Dr. Zeltner, you had mentioned that part of the way that you shifted from an employer-based insurance plan to individual coverage was by providing extra money to the employers, and I'm just curious, or to the employees to cover their insurance. And how exactly did you do that? Was it by giving a tax credit to employers to increase the wage? Did you increase the minimum wages? How exactly was that accomplished?
That was actually, it was, financially neutral for the companies, because the companies in the past paid a certain amount of the healthcare premiums to the healthcare company. And this part was not paid by the employers anymore to the company, but was given to the employee in order to pay for the premiums. And that was just on the basis, but given the fact that in Switzerland, the engagement of the employers was never at the level of the US. Most employees already before the reform had their own plans. It wasn't too big a problem.
Thank you very much. Well, we would like to thank you, Thomas, for taking the time in your busy schedule. This was a wonderfully stimulating, thought-provoking, and I'm sure I would not be surprised that new projects will emerge on both sides of the Atlantic as a result of our dialogue. I look forward to our collaboration with you, your health system, your foundation, and I hope to discuss this after our presidential election, because there may be a new beginning, we hope. All the best to you, safe travels, and stay happy, all of you who've come to join us from around the world and the United States. This has been most enlightening. The session has been recorded. It will be available. So I look forward to our continued collaboration on this and related matters. Thank you very, very much. Thank you.
Thank you, and all the best to you and your country. I really hope that things will turn to a good end. Thank you.
Thank you. Thank you. Bye-bye.
Bye.
Bye-bye.
Mhm.